Hello class, and welcome to your Chapter 9 lecture. Today we're going to be discussing narcotics and opioids. So the learning objectives for today's lesson are that by the end, you should be able to describe the principal pharmacological effects of narcotics, their biological targets, and their main therapeutic uses. Identify the major side effects of narcotics and their abuse potential. Distinguish between narcotic physical dependence and addiction. Identify the abuse patterns for heroin and outline the stages of heroin dependence. List the withdrawal symptoms of and potential treatments for narcotic dependence. Describe and compare the use of methadone and buprenorphine. Explain the connection between abuse of prescription opioid narcotic drugs and heroin. Identify the unique features of fentanyl. Describe how designer drugs have been associated with narcotics and Parkinson's disease. Describe why dextromorphan in cough medicine is abused. And identify the opioid features of tramadol and its potential for abuse. So by way of introduction, in 2018, it is estimated that 2 million people had an opioid drug use disorder. 900,000 of those were abusing heroin specifically. Of those who died from drug overdoses in 2014, 40% were related to prescription opioid pain relievers. In 2014, there were approximately 500,000 adolescents that were non-medical users of opioid analgesics. And women are more likely to use prescribed opioid analgesics, receive higher doses, and use them for longer periods of time. So what are narcotics? Well, for this lesson, narcotic is going to refer to opioid narcotics because of their association with opium. So narcotics are a CNS depressant that produces insensibility or stupor. They're naturally occurring substances derived from the opium poppy plant, and they're synthetic substitutes. So again, we're going to look at opioid narcotics. They're going to be what we're just calling narcotics for this lesson. So what do narcotics do? Well, they activate the opioid receptors, and they do have abuse potential. They can be prescribed as an analgesic or an antitussive or to reduce diarrhea. So as an analgesic, this is to reduce pain, and as an antitussive, this is to reduce coughing. So some examples of narcotics can include heroin, morphine, methadone, oxycodone, and tramadol. So let's look briefly at the history of narcotics. So there's a 6,000-year-old Sumerian tablet that actually has an ideograph for a poppy that's shown as joy plus plant. Additionally, Egyptians listed opium as a medicinal compound in Ebers Papyrus around the year 1500 BC. So poppy has been around for a very long time. Arab traders then introduced this opium to China and India. So looking at opium in China, as they began growing their own opium, we're going to look at a timeline here. So we're first going to start with 1729, where the sale of opium was outlawed in China. So the penalty for disobedience was death by strangulation or decapitation, which seems a little severe by today's terms. Later, China forbade the importation of this plant from India. So, however, the British East India Company actually encouraged cultivation of opium and were the principal shippers to Chinese port of Canton. So smuggling routes had to start developing because they outlawed this. Then we had the Opium War, the first Opium War, from 1839 to 1842. So the British sent in an army, and Britain won, and China ended up having to actually pay for the cost of the destroyed opium. Then we had a second Opium War in 1856, and in this one, China had to make even more concessions to Britain, and importation continued to increase into China. So because we had the British East India Company that was encouraging cultivation, but the Chinese government that was discouraging it, that's why these wars broke out. And then in 1908, there was finally an agreement between Britain and China to limit opium imports from India. Now we'll go into the history of narcotics, specifically looking at American opium use. So in 1803, Frederick Sertner extracted and partially purified active ingredients in opium, and these were actually 10 times more potent than the original opium out of the plant, and this was morphine. Then in 1832, codeine was discovered, so this was a second compound that was purified out of opium. In 1853, the hypodermic syringe was perfected by Alexander Wood. So injection of morphine actually increased its potency and likelihood of dependence. But this was administered a lot during the Civil War to treat pain, dysentery, and fatigue. Opiate addiction then became known as the soldier's disease or army disease for this reason. Moreover, the drug problem worsened because we had Chinese laborers bringing opium to the United States to smoke it. The availability of purified morphine and the combination of the hypodermic syringe, which again made it more potent, made it more potent and increased the likelihood of dependency. And the third reason is because there were a lack of controls on patent medicines that contained opium derivatives. So there were some medicines that were containing opium. Then in 1898, we see heroin come onto the board. So heroin was actually marketed by Bayer as a cough suppressant, and it was also used to combat addiction to other substances. Then in 1914, we have the Harrison Narcotic Act that was passed. So here we see there was regulation of opium, coca leaves, as well as their products. In 1824, heroin was finally banned from U.S. medical practices, so heroin could no longer be used for medicinal purposes. And in the mid-1980s, smoking heroin instead of injecting it became popular in response to the AIDS epidemic. So in an effort to reduce the chances of getting AIDS from using a hypodermic needle and injecting it, instead users started smoking it. So if we look at some pharmacological effects of narcotics, we're first going to start with narcotic analgesics. So most commonly, narcotics are prescribed to relieve pain. So they can relieve visceral and somatic pain, as well as some pain that's associated with certain types of cancers. So visceral pain is going to be those that are associated with internal organs, while somatic pain is associated with your muscles, bones, skin, and teeth. They do activate the opioid receptors that are controlled by endorphins. And the endorphin system is also influenced by psychological factors. It is a natural activation of opioid receptors that contributes to the regulation of emotional behaviors, such as stress, learning, and memory. So physiological, psychological, and pharmacological factors are all intertwined when we're talking about pain management and using opioids to reduce pain and to manage pain. So therefore you need to look at all of these different factors and address all of them when you're talking about pain management through an opioid system. You can't address just one. They're administered orally, injected subcutaneously, intramuscularly, or intravenously, or through transdermal patches. So there's a few ways that you can have narcotics enter your system. And OxyContin is probably one of the most famous prescriptions that everyone would be familiar with. So the approximate potency, it has the approximate potency of morphine, and it's obtained with relative ease, and unfortunately was overprescribed by doctors, which is why we see a lot of individuals who were abusing OxyContin when it first came out. A few other therapeutic uses we see that are worth mentioning are that they can be used as cough suppressants. They also slow the movement of materials through the intestines, so it can help to relieve diarrhea. Though, with all of these therapeutic uses, it's important that we have guidelines for clinicians so that they can avoid unnecessary issues with patients that they prescribe opioids to. So again, the issues that we saw with the OxyContin epidemic, these are some guidelines that they give to clinicians to hopefully avoid those epidemics. So they should only be used for pain when severity warrants it and when a non-opioid pain medication has already been considered. The dosage and duration should be limited as much as medically possible. The patient should also be informed of how to store their medication securely so that others cannot obtain it, especially teenagers, children. Clinicians should also screen the individual and the patient for their risk of abuse and addiction and know their history of abuse and addiction with other substances. They should establish a treatment plan with the patient that gives them measurable goals, as well as informing the patient of the risks and benefits that can result from using these drugs through a written contract so that there is written documentation that the patient was informed of both risks as well as the benefits. And finally, that prescription use should be discontinued if the terms of that contract are not being met by the patient. So if the patient is taking more than they are being prescribed, if they're using other drugs along with it, then that clinician has the option to discontinue the prescription if they feel it's being abused. So let's go into abuse of prescription opioid painkillers. So addiction to prescription narcotics can result from being prescribed by doctors for pain, injuries, surgeries, and other reasons that they would prescribe for medical reasons. The risks for vulnerability for one to abuse these painkillers includes a family history of substance abuse, that person being dependent on either nicotine, alcohol, or sleeping pills, depression, use of other psychiatric medications, being younger than the age of 65. However, when these painkillers are used appropriately, the risk of abuse is about less than 1%. So there really is not a risk for abuse when they're being used appropriately and as prescribed. However, addiction to prescription painkillers has led to an increase in heroin use, specifically because heroin is more accessible, it's easier to obtain, and is about 1/5 the cost of opioid painkiller prescriptions. So how do these act within the body? What are their mechanisms of action? So endorphins will serve as neurotransmitters and will stimulate the opioid receptors, which block pain through spinal cord or the brainstem. Endorphins are released into the brain, spinal cord, and from the adrenal glands, typically in response to stress and painful experiences. The endorphin system is also influenced by psychological factors and can be naturally released. The endorphin transmitter is found in the nervous system, in the intestines, as well as in internal organs. So there's also a high concentration of opioid receptors in the limbic structures of the brain. So stimulation of these by narcotics causes dopamine to be released. So the release of dopamine then contributes to the rewarding actions and leads to dependence and abuse. So when one does begin to abuse these painkillers, what are some side effects they'll experience? Well, side effects are typically the result of the widespread distribution of opioid receptors found throughout the body and their involvement in many physiological functions. So some of those side effects can include constipation, which is the most common, drowsiness, mental clouding, respiratory depression, nausea and vomiting, itching, an inability to urinate, having a drop in blood pressure, and constricted pupils. So an opioid antagonist, on the other hand, can cause, so an opioid antagonist would be one that antagonizes the opioid or has the opposite effect. So naloxone, for example, is one that would be administered to combat the effects of an opioid. So what happens is these cause, one, the recurrence of pain in patients who are using a narcotic for pain relief. They can also cause restoration of consciousness and normal breathing to an addict who has overdosed on heroin. And finally, severe withdrawal effects in opioid abusers who are dependent on narcotics. So it can worsen the withdrawal effects. Moving into abuse, tolerance, dependence, and withdrawal, there is a distinction between physical dependence and a compulsive need to use. So someone may develop a physical dependence and experience temporary withdrawal when they're weaning off of a narcotic from medical treatment, versus someone who has a compulsive need to use that drug despite the negative consequences that come along with it. Tolerance of these drugs can actually begin at the first dose, but they're typically not clinically evident until about 2 to 3 weeks later after frequent use. So this does occur most rapidly when someone is taking high doses that are given in very short intervals. And the result of tolerance is an increase in use of that drug to hopefully regain the effects that that person once achieved with smaller doses. And developing a tolerance to just one narcotic also means that that person is going to develop a cross tolerance to all drugs in the narcotic group. When dependence develops, you can have it being in the forms of physical or psychological, and it makes for an uncomfortable and unpleasant effects of withdrawal. So you can have an exaggerated pain response, agitation, anxiety, stomach cramps and vomiting, joint and muscle aches, a runny nose, and just overall flu-like feelings. So now that we know what it looks like when one is abusing these drugs, the actions it has within the body, let's look at heroin as a drug. So about 4/5 of heroin users started by misusing prescription painkillers and developed a tolerance to the painkillers and then switched to the heroin because, again, it was cheaper, easier to get. Heroin is a Schedule I drug, so it is not approved for clinical use. Today, Mexico is the primary supplier of heroin to the United States, and it is about 95% pure when it enters the US, but that can range from as low as 3 to as high as 70% when it finally reaches the user. So heroin is typically cut with a few different types of substances. The first one we'll talk about is lactose. So it can be cut with lactose to give bulk and increase the profits, so to make it appear that there's more product than there really is. Quinine can give it a false bitter taste, so heroin has a bitter taste to it. So they'll add in this substance to make the user think that there's more, or it's more pure than it truly is. But this is a deadly adulterant, and it can also act as an irritant, so it causes vascular damage and has lethal disturbances in heartbeat and respiration. Mannitol has a laxative effect, so this helps to counteract the constipation that is caused by heroin, so sometimes they'll mix it with this substance. And one that I'm sure we've all heard of at this point is fentanyl, and this has an unexpected potency, but a very extreme potency. So when they mix heroin with fentanyl, it's a synthetic narcotic with an extreme potency, so you don't know how potent it truly is, which is why sometimes if you even touch certain doses of fentanyl, it can get through your skin and also have an effect negative effect on the body. So when we look at heroin combinations, drug users will combine heroin with other drugs. So they'll typically, what's called speedballing, is decreasing the amount of heroin they're ingesting while increasing the amount of cocaine to either self-withdrawal or detox from the heroin. This is called speedballing. So the cocaine is going to give them relief from the heroin withdrawal symptoms, which is why they decrease their heroin use while increasing the cocaine use. So let's look at the heroin abuser. There are 600,000 to 1 million active heroin users. We have over 10,000 deaths annually from this drug alone. The various methods of administration we can have are injecting either into the muscle or under the skin, or mainlining, which is injecting the drug intravenously, and this is typically what's preferred by addicts. However, once a vein collapses from frequent use, that vein can no longer be used, which is why you'll see users trying to stick themselves in many different places. Some will also try and stick the needles under the tongue, between the toes, and other places that are vicarious, so that others from the outside don't see the track marks, that they don't see that they're a heroin user. You can also sniff or snort the drug, smoke it. So there's many different ways here that you can administer heroin. So the profile of a heroin addict, when we look at this, we need to discuss shooting galleries. So these serve as gathering places for addicts. Typically they use houses or abandoned cars or even parking lots. There may be someone at the gate or at the door who charges an entrance fee for the addict to come in and be able to use it. Conditions are typically filthy. And because of this, some states have actually created government-regulated galleries to prevent the spread of disease, to ensure that there's sanitary conditions where users are injecting the drug, and to hopefully regulate use, so that if an addict is using, they don't overuse. So some users can actually become addicted, or so they have reported, that they become addicted to the actual act of injecting. So there's a fixation with the needle and the syringe that your textbook notes is related to some sexual overtones. So there could even be an addiction to simply the act of shooting up, in addition to the effects of the drug itself. AIDS and hepatitis are also another concern, as well as other communicative diseases that spread quickly because one of the intravenous use, so using needles that others have also used, and because of the risky sexual behaviors that these users engage in while they're high or while they're under the influence of the drug. So neonatal abstinence syndrome is present in newborns of heroin addicts. So this can be controlled through opioid drugs such as buprenorphine to slowly wean the infant off of the heroin and to help control the withdrawal symptoms. Symptoms of this typically include a high-pitched crying, the newborn being inconsolable, having a tightened muscle tone. They can even have tremors, vomiting, seizures, and death can also result. So it's also been reported that this increases the chances of sudden infant death syndrome occurring. And each year, there's estimates of upwards of 7,000 infants being born to heroin abusers. When an individual is dependent on heroin, let's look at some of the dependence and withdrawal symptoms that can occur. So we have a few different stages of psychological dependence. The first stage is the rewarding stage. So this is the euphoria and positive feelings and sensations that are going to increase with continued use of the drug. Our next stage is then avoidance of withdrawal symptoms, and these symptoms typically start about 6 to 12 hours after they've had their last dose. Withdrawal symptoms, so severe withdrawal symptoms are going to be referred to as dope sickness. So here we have just a rough timeline of the different withdrawal symptoms that users may experience. So 4 to 6 hours after use, they may experience a runny nose, tears, minor stomach cramps. That 12 to 48 hour mark, they may have a loss of appetite. They may have vomiting, diarrhea, abdominal cramps, chills, and a fever. 2 to 4 days after their last dose, their bones and muscles will ache. They may have some muscle spasms and violent kicking motions that they can't control. And then about 4 to 5 days after use, the symptoms should hopefully begin to subside. So with heroin use also comes crime. So drug arrests for heroin increased 700% between 1960 and 1971. Heroin-related crimes actually cost the United States roughly $3 billion every year. So what are some other factors that are related to heroin use and crime specifically? Well, heroin use encourages antisocial behavior that is crime-related. So the use of heroin diminishes inhibitions, so users will do things that they wouldn't normally do. They typically become more self-centered and impulsive, especially while they're under the influence. Being addicted to heroin is very expensive, so they may commit crimes to support their habit. They may rob, steal, even sell their body. And there's similar personalities that are found among heroin users and criminal behavior. So heroin addicts typically become involved in crime about the same time that they start using heroin. So antisocial behavior causes criminal behavior, not vice versa. How do we treat heroin addiction then, or dependence on other narcotics? So successful treatment is going to look like the person has stopped using heroin. They may now no longer associate with dealers or users. They will typically avoid dangerous activities. They've improved their employment status. They'll refrain from criminal activity and enjoy normal family and social relationships. So this is what successful treatment looks like. You see, there's a few different components, and it doesn't just mean that the person is no longer using the drug. You have all these other factors to show that the person is improving their life and improving their quality of life. So a dependent user may also use a maintenance narcotic to withdraw and in their treatment of their heroin addiction or narcotic dependence. So these maintenance narcotics are long-lasting narcotics to substitute those short-acting narcotics, such as heroin, through drug treatment centers under the direction of trained medical personnel. These maintenance narcotics are given orally, so the onset is too slow for the user to cause them a rush, so they don't feel that high that they would feel from, say, heroin. It also helps to manage their withdrawal symptoms and reduce their drug cravings. It's also more cost effective, so it costs roughly $3,000 every 6 months compared to $21,000 for a heroin user. One of the examples of this is methadone. So an individual may be on this the rest of their life. It is a long-term solution. However, it does have the potential to be abused, and inappropriate use can cause death. We then have buprenorphine, which is an analgesic, and it has a minimal abuse potential and has also been approved for use in primary care settings. So this means that primary care doctors are now able to, I believe it's around 100 patients, they're able to prescribe this long-acting narcotic to treat them in a primary care setting as opposed to under a drug treatment center. It just means that more addicts have more access to treatment. And then Vivitrol. So this is an extended release form of naltrexone, And the whole point of this is to reduce cravings for the narcotic, and this is given through monthly deep muscle injections. The question arises, however, are we simply trading one addiction for another when we do this? This way, however, does prevent the spread of infectious diseases and allows people to return to a normal, productive life. To be successful, these maintenance narcotics must be combined with counseling in order to modify those drug-seeking behaviors as much as we're modifying and addressing the dependency behaviors. So this is just a list of other narcotics. So the one I really want to go over here is MPTP. So this is a synthetic heroin that was created by attempts to synthesize meperidine-like drugs by amateur addicts. So it simply results from careless synthesis and is metabolized to a highly reactive molecule in the brain that selectively destroys neurons containing the neurotransmitter dopamine in motor regions of the basal ganglia. So we see similar neuronal damage to what we see in classical Parkinson's disease that one would see over 50 to 70 years time span of someone who has this disease. The drug MPTP accelerates this degeneration to just a few days. So it's a very, very dangerous synthetic heroin. So other narcotic-related drugs include kratom, which is recreational and medicinal uses. This is a plant that grows naturally in Asian countries, and it's not yet illegal in the United States, but it claims to treat pain and withdrawal, but that is not substantiated by the FDA, so it cannot be legally marketed in the US. And this drug does have the possible abuse potential. Then we have dextromethorphan. So this is actually used in cough remedies. It can be purchased with a prescription, and it does not have an analgesic action, and it does not cause the typical narcotic dependence. We see misuse, however, by teens and young adults because it causes an altered perception, a sense of floating. It can also cause hallucinations, visual distortions, paranoia, and even psychotic reactions if used in high enough doses. Clonidine is a non-addictive, non-euphorogenic prescription for relieving some physical symptoms of withdrawal, but it does not address cravings or aches. It can, however, shorten withdrawal time to just 2 weeks as opposed to several weeks or months. And then we have naloxone and naltrexone. So these are narcotic antagonists that will either block or reverse the effects of a narcotic. So it rapidly reverses the life-threatening effects such as breathing or effects to your breathing or the cardiovascular system. However, this can initiate severe withdrawal. So this is what first responders typically carry on them, naloxone or naltrexone, and they'll administer this to someone who has overdosed or is in the process of overdosing, typically on heroin or another narcotic opioid. So again, it can reverse those effects, so it can kind of bring them back to life, so it seems, but that can also then initiate those severe withdrawal symptoms. And just a few natural narcotic substances that's worth mentioning. So these are naturally occurring opioid drugs found only in the opium poppy. So things such as morphine, codeine, you have heroin and thebaine. In sum, narcotics act on endorphins, which activate opioid receptors to block pain. Stimulation of opioid receptors in the limbic structures in the brain cause dopamine to be released, which gives pleasure sensations. The therapeutic uses of narcotics include pain relief, a cough suppressant, and anti-diarrhea. Side effects of narcotics can include the abuse potential, constipation, sedation, respiratory depression, nausea and vomiting, the inability to urinate, or a drop in blood pressure. Physical dependence to narcotics occur when the withdrawal symptoms present, versus addiction, which is the compulsive need to use despite the negative consequences. Abuse patterns for heroin look like unpleasant and dysphoric sensations that then lead to feelings of euphoria, which leads to psychological dependence, leading into physical dependence and ultimately to abuse. The stages of heroin dependence include the rewarding stage and then the avoidance of withdrawal symptoms stage. Withdrawal symptoms can then range from having a runny nose and minor stomach cramps, to vomiting, diarrhea, chills and fever, to aching bones and muscles, and to even muscle spasms. The treatment of narcotic dependence includes the use of methadone and buprenorphine, which has also been approved for primary care settings, and it's actually safer for treating opioid-addicted newborns. Abusers of prescription opioid narcotic drugs will often switch to heroin because 1, it is cheaper, 2, it is more accessible, and 3, it is easier to obtain. Fentanyl is a highly potent synthetic opioid narcotic that is often cut with heroin. MPTP causes symptoms that are identical to Parkinson's disease, but they present in only a few days rather than a 50 to 70 year time frame, and is actually now being used to study possible treatments for the disease. Dextromethorphan in cough medicine is abused mostly by teens and young adults for its potential to cause hallucinations and sensory distortions. And finally, tramadol is a Schedule IV controlled substance that has analgesic properties and also some antidepressant actions. So that was your lecture for this week. As usual, if there are any questions, feel free to reach out. I hope you all have a lovely week.